Okay, I don't see any other questions. Again, thank you very much. We are going, excellent presentation. We're going to now move on to item number 3, brief overview of governor's proposal and follow up from the July 2nd hearing. We have with us this morning Jennifer Kent, Director of Department of Healthcare Services. Good morning, Ms. Kent. Welcome.
Thank you. Good morning, Senator and members. I wanted to give you a brief update on the MCO tax discussions that we've been having with the plans and with the administration to date. As you may recall, we've had several iterations of a tax on managed care plans in Medi-Cal over the years. The first one was removed via a change in federal law. And when we did that, that was the time in which we did a gross premiums tax on Medi-Cal plans exclusively. That was back in 2008, 2009. And at the time, that gross premiums tax was agreed to by the plans, primarily because it went to continue funding for what was the Healthy Families Program. When the Healthy Families Program was rolled back into Medi-Cal managed care, there was a change, again, by this legislature where we moved from a gross premiums tax to a sales tax, which is what we have today. And what has really occurred, and not just in California, but in a few other states, we have a managed care tax that only the Medicaid plans pay, and we pay the tax back to them through their rates. And so, in essence, there has never been harm or loss to those plans that pay the tax. The federal funds are drawn down by the tax receipts that we use, and the plans don't have any kind of negative impact. And so that has been obviously extremely successful. It means about $1 billion to us annually ongoing right now. The federal government looked out across the landscape at states and saw that there were several of us doing this, and felt that that was something that was impermissible. There was a Inspector General report in Pennsylvania that essentially called CMS out and said, you cannot continue to do this. And so they promulgated a letter last summer and said that the states that were participating in this activity had to change by the end of our legislative session. And so what we interpreted that letter to mean is that we have until next year to come up with a new broad-based tax that meets all of the federal standards. So we have engaged as early as obviously January when the governor put forward a proposal to come into compliance with a provider tax. Provider taxes are very different than the way that we have been doing business to date. And when we say broad-based, it means that plans across all their lines of business have to pay a tax. And that is really where we have run into a little bit of a challenge, because obviously, as you heard from the witness before, taxing a plan across all lines of business has ramifications for both the individual market, the large group market, for plans in terms of their competitive advantage with each other in market areas. I think when we looked at our Medi-Cal managed care plans, when we were structuring this tax, we took that into account as much as possible in order to meet the federal standards. So when you notice the 5 tiers in the governor's proposal, you'll notice that we put the heaviest amount of tax on the Medi-Cal managed care plans. These are plans that we did an enrollment-based tax on, and ideally what we're trying to do is generate as much tax to the Medi-Cal plans. So again, we have as little harm as possible to the payer. Obviously, in order to meet the federal standards, we taxed across all the different lines of business based on enrollment, and what we were also trying to do was mitigate as much harm on the largest plans in the state, obviously not wanting them to pay a disproportionate share. So we have been engaging in ongoing conversations with the plans, to date since January, and I have to say that they have been good partners. They have been participating in conversations with us. They themselves have been taking the model that we have created and really trying to work it in any other way. We have modeled revenue. We have modeled, premiums, we've modeled enrollment numbers, we've modeled all different kinds of things, and I think there's a real willingness to try to figure something out. And so I would have to just, comment on the fact that for plans that don't participate in Medicaid today, their willingness to engage in a conversation with the administration and how we fill this, over $1 billion potential hole has really been positive. We don't have anything, successful to date, but I think that we are continuing to talk about various options. And so with that, I can, stop and pause for questions. But I think that, again, the federal challenges have really been both difficult, and it's telling in that no other state, to our knowledge, is even trying to re-engage in this kind of a broad-based tax. And so with that, I will open up to questions.
Thank you. Is there any questions from any of the members? Yes, Senator Pan.
Thank you, Director Kent, for that update. I recognize that the proposal to create the various tiers with different rates was an effort to try to maximize the opportunities for the Medi-Cal managed care plans, which generally tend to be sort of, I guess, I call mid-sized or plans or so, that middle tier. But at the same time, and you mentioned this in your testimony, that there are also plans, mid-sized plans that don't do a lot of Medi-Cal business and who would be competitively disadvantaged in trying to compete with, let's say, larger plans who would have most of their enrollees at a lower rate because they're larger, given the nature of the tiers. And the potential result of that could be is that we have a situation where the mid-sized plans are essentially driven out of business or bought up, and we would have no mid-sized commercial plans because of the disadvantage. So given the federal rules that have now been promulgated, is it from the, and again, I realize this is sort of guessing what the feds will say, but you do interact with them. Are they going to look at that in the future, and not necessarily a distant future, and say, well, actually, there's a disproportionate, actually, this is a tax essentially on Medi-Cal, that we're back to the same situation we are in now, because there effectively aren't any mid-sized commercial plans, and you really are basically taxing Medi-Cal plans, and so it's not a broad base. Are they going to simply look at the mechanism and say, well, look, the mechanism technically is that way? Or are they going to look at the results and say, well, actually, all your Medi-Cal plans happen to be in one zone, and that's where you're putting most of the tax, and that the rest of them you're not, and that it's no longer a broad-based tax. So I guess it's I'm asking for your interpretation of the federal rules and how they plan, and your conversation with CMS and how they will look at them both now and essentially in the future as well.
Well, I think, this provider tax, and that's a certainly fair question. I think, when you talk to the federal CMS officials about a provider tax, in general, they say it's Medicaid money. So if you want the Medicaid dollars to flow to your state, you have to do it our way. So they're pretty straightforward about that. I think that what makes this tax a little unusual, we have a hospital tax in the state as well as a nursing home provider tax. Those work a lot easier because essentially all of the providers, with very few exceptions, take some portion of Medi-Cal. And so you have a very different kind of business model and relationship, whereas in California we have 22 contracting plans with Medi-Cal today, but there's obviously a lot of plans that don't participate in Medi-Cal. And the nature of a provider tax means when they say it's broad-based, it means you have to tax all of them, and you can't have all winners. And so this whole winners-losers concept really comes in more when you don't have as many providers in the Medicaid market. And so I would, like to think that they are somewhat sympathetic to states trying to figure out a way to make this work, but I think that they would ultimately say it's a provider tax. It has its reasons for why we do it, so that states essentially don't game the federal financial participation. And so that is kind of the dynamic that we find ourselves in, is trying to minimize as much damage as possible to the outside commercial market. We want to retain, obviously, competitive market forces that are not necessarily related to Medi-Cal, but we're also trying to meet the federal tests as much as possible. So it's a difficult challenge.
Okay, yeah. So my concern is actually, well, we may be reducing choice. I mean, we may basically have several large plans because they're going to, they have both Medicaid economies of scale, and also they're going to have a tax advantage now compared to mid-sized or regional plans, and we may be creating and so we may essentially eliminate them from the market with this tier, and potentially still run into challenges with the feds, because they may say, well, actually, given your nature of your market, you essentially all you have are you're mainly taxing Medi-Cal plans because the rest of those plans don't exist anymore at that point. I guess the other question is the HCS looking at, if we're looking at trying to, you have to use the broad-based provider tax, essentially opening up the Medi-Cal managed care market and essentially letting more plans potentially participate, and so that they can, so if you're going to have a broad-based provider, that they all can get a piece of the Medi-Cal market. Obviously, we want to be sure there's sufficient oversight as well, but is that something the HCS is looking at?
Yeah, so that has been asked of us by both members and by plans that are interested in participating in Medi-Cal. So we have 3 different markets, or 3 different models in Medi-Cal managed care today. We have geographic managed care, county organized health systems, and what we call the 2-plan model, in which there's a local initiative created on a local basis. It's a quasi-governmental health plan that competes with a commercial plan. We have, pursuant to a lot of litigation that was filed against us on rates dating back to 2003, we as a department have agreed to settlements with several plans that essentially give them a market in those 2-plan areas anywhere from 2018 to 2022, depending on the service area. So that makes it difficult. The county organized health systems are federally created, so that also, given federal changes, are a different animal. And then geographic managed care, we are preparing to release requests for application for both Sacramento and San Diego counties in which plans can apply to participate. The challenge on that is that even if a plan all of a sudden gained entry into Medi-Cal, it's only 2 counties, it's such a small enrollment, and so your tax cannot be returned in its entirety just based on your Medi-Cal enrollment. The only tax that gets returned to you is the tax that you pay on your Medi-Cal lives. So it's not necessarily a silver bullet solution for plans that just think that if they take Medi-Cal that they can somehow really offset that loss in a different way. So it's just another complicating factor to Medicaid in general.
Sure. And certainly as the senator from Sacramento, I don't think our county can bear the whole burden for the rest of the state.
No.
Thank you.
Okay, I believe Senator Leno, then we're going to go to Senator Nielsen, and I believe Senator Morrell had a question. Senator Leno?
Thank you, Mr. Chair. Director Kent, my question is somewhat related to Senator Pan's regarding the federal requirements. And I'm looking at some notes that reflect the letter that was sent to the state back in July of last year, and that the 3 criteria include that they be applied to all providers in a class, which you've already described to us, of course. Secondly, they are applied at the same rate for all payers, short of a waiver. How do we do tiers without a waiver, or are you depending upon a waiver?
So when you do provider taxes, you either have to apply the rate at the same rate, or you can do tiers, but you have to meet certain statistical tests. So there's a whole rule of federal requirements that you can otherwise opt into. And so when we tier it, there's something called an A1 and a B1 test. There's statistical tests that make sure that you are still assessing based on that you don't have a hold harmless, and that you're still making it compliant. And so we, in the model that we have run, we meet all of the statistical tests for how we have done it.
So for my basic understanding, applied at the same rate for all players does not preclude tiering.
Correct.
Okay.
That is correct.
And then lastly, cannot directly or indirectly guarantee that providers receive their tax back.
Correct.
So with those 3 criteria firmly in place, and your further explanation of the second one, do you have hope that there is a way to figure this conundrum out? And let me fold into that question. You had said that negotiation, everyone's been earnest negotiators, which is a good thing. I'm glad to hear that the negotiations are merely ongoing, or that they're ongoing and we're making progress?
They're both ongoing, and I am optimistic.
I like that.
I am eternally optimistic.
We have to be.
Yes, exactly. The hold harmless is also, as you note, the 3rd criteria, which makes it, again, very challenging, because obviously if we were to do certain things where we said we promise that we will, for the commercial plans, we'll return the money to you in some other way. The federal government would say that's a hold harmless, and so you can't, in whole or in part, agree to make plans.
And directly or indirectly.
Yeah. And so that just, again, we have overcome that in both the hospital and the nursing home. Taxes that we have in place, I think that there are certainly, I think these kind of challenges bring out creative thinking. So we have a couple of really, really smart people that are continuing to toss around different options and stuff. And so I just think that I would like to think that we are always in the ballpark of possibility.
And my last question, Mr. Chair, is do you have any thoughts that you can share with us with regard to the concept of the alternative, which would be a flat tax structure as opposed to tiered?
So the flat tax, while seemingly more elegant, right, in terms of it's just more simple, in terms of it's not tiered, has a disproportionate share impact on the largest plans, right? So if you're doing a flat tax based on enrollment, what it does is it really kind of moderates those small to mid-range plans in terms of they, have a very kind of small and safe impact, whereas the very, very large plans in California pay an extraordinarily higher amount. And so I think that that makes it, in some cases, we were trying to moderate that impact as much as possible in ours. There's also some challenges, I think, that in the particular model with the flat tax that's been proposed is there was an exemption of a couple of plans where we've provided technical assistance to say you can't exempt certain cross-border plans. We had included those in our model because, again, back to the broad-based. So I think a flat tax works in some very elegant, easy, simplified structure, but it means that your largest plans in California would be paying an extraordinarily higher amount than they otherwise would. And so that, in some cases, makes it more difficult for them when you're talking hundreds of millions of dollars more that are burdened on 3 plans more than others.
And again, I'm learning just by listening from you today, so you know a lot more about this than I. And so just naive questions here. If the concern for many of our colleagues is that this, in effect, does get passed on to the premium payer, is there something more equitable at the premium payer level of the flat tax because everyone will be paying the same, at least as I understand it? Clearly a plan that has X number greater policy holders will, in the aggregate, pay more, but at the premium payer level, is the flat tax concept that everyone pays the same?
I'm thinking. I think,
hope I described that well.
I think it depends on the plan, right? So each plan has different product lines or different sizes. So if you have a flat tax and you are a predominantly small group plan, obviously your small group purchasers are going to be paying for that increase. Whereas if you're a mid-sized plan with a very small group product line, but a large Medicaid product line, a flat tax is obviously going to not impact your ratepayers in the same way. So I think it really depends on the individual specifics of the plan as to whether that's really, truly true. I'm kind of thinking through how that would get passed down, and so I would say it probably depends on the plan.
More complex than it looks.
Always.
Always.
Right.
Thank you.
Thank you. I believe Senator Nielsen had a question, and Senator Morell.
Thank you, Mr. Chairman. Director Kent, there are other options available that would not provide the opportunity to rate increases to the consumer. In this budget, there was $10 million additional revenue that could have been used for this rate increase provision. That did not happen. I think it should have. But it is anticipated that we're going to be accruing additional revenues as the year moves on. There's a possibility that that could be used. And in addition, is it not correct that the MCO tax does not expire till next year, correct?
Correct.
So we could go into next budget year, and if revenues improved, then we could fund the rate increases from that next year.
Well, so
It doesn't help us this year, and there is what I'm suggesting, there would be revenues this year, but I'll get to that in a minute, but to these points.
So the MCO tax that we currently have, and it supports the overall Medi-Cal budget to the tune of about $1 billion. Come January, when the governor has to present a budget to the legislature, our tax expires on June 30th of 2016. His January budget is going to be for 16-17, and so if the tax has not been enacted, obviously within the special session, that is a very difficult, and it's a large revenue source to not have in place and secured for the budget in January. So I think that's what the urgency is from the administration's perspective is come January, my overall general fund budget for Medi-Cal is about $18 billion. So removing $1 billion out of $18 billion is a significant loss of revenue. That is just, and we are engaged obviously in this discussion to just secure that source. Any additional funds for rate increases are separate and apart from the filling of the MCO tax. And so it is true that the revenue will exist until June 30th of 2016, but to the extent that it is not either finalized or close to finalization, that will present a really difficult budget in January because it would not be really responsible to count on $1 billion if it's not really there.
Well, that gets to my other point, and I've suggested this before. We are suggesting it now, a trigger. In vast budgets, we've suggested the idea in budget negotiations of a trigger. I would argue that effecting a trigger, the first revenues would go Prop 98 and Prop 2, but then any extra revenue could go then to a provider to restore the increase that we didn't complete this year. I'd like you to consider that, the administration to consider that trigger mechanism. We could put that into effect. That'd give you an assurance that if there's revenue, that is to the premise, and we just don't need to tax. We don't need to put impacts on increases in premiums, but we're doing good budgeting. We're using money that we actually know we're going to have. And that short of a tax increase, you see. Would you make a consideration of that? Yeah,
I think we're happy to talk with you further. I think that just on the natural, any additional revenue is always up for discussion and negotiation between the administration and the legislature as to the priorities of how you would like to fund it. To the extent that there's shortfalls in revenue, I think that that's where it gets a little bit harder, right? In terms of a shortfall in revenue in Medi-Cal means we have to. There's really 3 things that we can change in Medi-Cal in terms of the size of our expenditures. It's the populations we cover, it's the benefits we offer, and it's the rates we pay. You know, it's 3 things, and to the extent that we don't have those revenues in place, we are increasingly challenged in terms of the populations we cover because of the Affordable Care Act. There's obviously a set limit on what we can do there. Optional benefits have been touched in the past, and people don't really like to do that, but that's one option. And then obviously provider rates, which is a continued source of discussion between us and you in terms of how we pay providers. But, if revenues are there, obviously the legislature and administration can, fund additional things. But if the revenues are not, then we have to, reduce somewhere. And so I think we're happy to have a discussion with you about that.
Well, I think that accomplishes both purposes, and there is confidence about the improving of the economy and the revenues that are available to the state. I think that's as assured we can get. If we have shortfalls, then rates are always vulnerable, and we're always going to have them on the table. But I think we should be looking at other than tax increases all the time. We do have that opportunity here. And one thing that's different this year, we don't have the unanimity amongst the providers of supporting the MCO tax. That's a very significant difference, and that makes it more difficult to balance. So I think this idea would have merit for consideration.
Great, thank you.
We have Senator Morrell and Senator Bell.
Thank you, Mr. Chair, and thank you for being here today. I just want to make one quick statement and then one question. The statement is, I just wish last year we would have been exercise more prudence with that $10 billion to helping these people. What's that? 10 billion? Yeah. Because again, the citizens want effective, efficient government with accountability. But here's my question. Why is it that the MCO tax now looks more like a general fund grab than a means to improve the quality and access to care?
So how the managed care tax has worked in the past and continues to work is it has always gone to fund managed care. So when I was describing how it was, how the gross premiums tax was initiated in 2008, 2009, the very simple policy goal was preserving approximately 700,000 children that would have otherwise been cut off of the Healthy Families Program. We taxed those Medi-Cal plans. All of them had Healthy Families business, and so it was a very good thing, you know, both for the beneficiaries as well as for the plans that didn't suffer any loss. I think that the money that has always gone in to support plan rates continues to do that. The general fund contribution towards managed care in our department, the $1 billion that we receive in general fund to support rates is a small percentage of what overall supports managed care. So the total fund budget of the Department of Health Care Services is somewhere around $94 billion. Managed care, I believe, within the estimate is about $60 billion of that. So $1 billion in general fund is really just a smaller support of a much larger budget that managed care receives.